growing up, there were lots of songs which probably derived their inspiration from diabetes. Songs like Sweet Home Alabama. So I wonder what's the incidence of type 2 diabetes in Alabama? Probably quite high. What about I'll take you to the candy shop? Do, 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 do. Do, 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 do. So 50 Cent, have you checked your GMs recently? And a friend of mine told me that he just went to his primary care practitioner who told him that his sugar is just too high. So you know what my friend did? He went home and he moved the sugar to a lower shelf. Hello everybody, it's Ryan here. I hope you and your family are well. Today we're tackling a global pandemic of sorts. Diabetes mellitus type 2. Hope you and your family are well. Thanks for joining me. This is the breakdown of our talk today. We're going to be covering a clinical case, then we're going to dissect type 2 diabetes 7 ways: etiology and classification, pathophysiology, patient presentation, differential diagnosis, diagnostic evaluation, treatment and management, prognosis of complications. Then we're going to encourage from the Word of God. And I just want to mention that the diabetic emergencies, diabetic ketoacidosis and hyperglycemic hyperosmolar state, I'm going to touch on that, but I'm going to dedicate a complete separate talk to that. I've already done a video on type 1 diabetes mellitus. This is just focusing on type 2 diabetes mellitus, all right? Here we go, guys. Fasten your seatbelt and put your helmet on. 37-year-old obese woman presents to her clinic for routine health evaluation. Now, she reports that over the last year, she has had 2 yeast infections treated with over-the-counter remedies, and she frequently feels thirsty. She reports waking up at night to urinate, so there's nocturia, there's polydipsia. Which of the following studies is the most appropriate first test in evaluating her for diabetes mellitus? Is it A, the HbA1c? Is it B, the oral glucose tolerance test? Is it C, your plasma C-peptide level? Is it D, plasma insulin level? Or is it E, a random plasma glucose? Well, okay guys, diabetes mellitus is a major independent risk factor for both coronary and peripheral arteriosclerosis, and we know that. The diagnosis of type 2 diabetes was reserved for older obese adults. However, with the astounding rise in the incidence of childhood obesity and diminished physical activity, physicians are now seeing an increase in the incidence of so-called adult-onset diabetes mellitus among the younger folks, the kids and the adults. Now, the United Kingdom Prospective Disease Study, the UKPDS trial, showed that intensive blood glucose control significantly lowered the rate of microvascular complications. The rising incidence of type 2 diabetes has both geographical and cultural differences. We find that there is a lower incidence in countries that eat diets which are low in animal fat and have relatively more physical activity, right? So this is the definition of diabetes mellitus as per the SEMDSA Guidelines. And the SEMDSA is basically Society of Endocrinology and Metabolism and Diabetes in South Africa. It defines diabetes mellitus as a metabolic disorder with heterogeneous etiologies characterized by chronic hyperglycemia and disturbances in carbohydrate, fat, and protein metabolism resulting from defects in either insulin secretion, insulin action, or both. What a beautiful definition. Guys, let's talk about etiology and classification. Let's just bring this down here. So in terms of type 2 diabetes, it occurs due to mostly insulin resistance, right, at the level of the peripheral insulin receptors, or there's impaired insulin secretion because of burnout of the beta cells, or because of increased hepatic glucose production. Patients may or may not require insulin supplementation, and diabetes type 2 accounts for more than 90% of diabetes overall. Now, there is a very, very, very strong genetic predisposition that increases with age and weight. We find that 80% of patients with type 2 diabetes are indeed obese. And the onset is very indolent. Patients may have had diabetes for years and even decades before they're diagnosed. Onset is usually after 40 years of age, but as we said, the disease is increasing in incidence among the younger folks. There is nearly 100% concordance for monozygotic twins. If one twin already has type 2 diabetes, the prevalence is increased among African and Asian population. So this is the International Diabetes Federation and their estimates in terms of the prevalence of diabetes. So in the world, in 2015, there were 415 million people, right, approximately, with type 2 diabetes, which is projected to increase by a whopping 55% come 2040, at which stage it is projected to be 642 million. In Africa alone, there were 14.2 million in 2015, which is projected to go up a crazy 140.9% by 2040, when we should be have about 34.2 million, right, with type 2 diabetes in Africa. Those with impaired glucose tolerance in the age group between 20 and 79 is projected to go up by 126.4%. Type 2 diabetes, as we know, these patients are more prone to HHS as an emergency, which is hyperglycemic hyposmotor state, in comparison with type 1 diabetics who are more prone to DKA. However, we are seeing cases of DKA as a novel presentation of type 2 diabetes, something we call the flappers variant. And diabetes mellitus, as we know, is a major healthcare issue, even beyond its effect on simply mortality and quality of life. It accounts for nearly 15% of the United States healthcare expenditure, quite a big chunk, right? Microvascular complications include nephropathy, retinopathy, and peripheral neuropathy, right? And, well, a whole variety of neuropathies. And macrovascular sequelae include cardiovascular disease, stroke, hypertension, and peripheral vascular disease. This is a beautiful table from the SEMDSA Guidelines outlining for us the main differences between type 1 and type 2 diabetes. So type 1 usually hits the younger folks, less than 30, but not always. Type 2 usually is the older, but we're seeing increased prevalence among kids and young adults, right? The phenotypic characteristics is that type 1 diabetic patients usually lean, and the type 2 is mostly overweight and obese, right? The onset of type 1 is acute, but the onset in type 2 is more grumbling, insidious, gradual onset. Type 1 diabetes almost always symptomatic with polyuria, polydipsia, weight loss, but type 2 often asymptomatic. Like we said, type 1 is prone to ketosis and often ketoacidotic at diagnosis off the bat, but type 2 not usually ketosis prone, but ketoacidosis may be present at diagnosis. We call that the flappers variant. Type 1 diabetes diagnosis usually has unequivocal hyperglycemia. Type 2 is often diagnosed during routine screening. Type 1 insulin is a necessity for survival, but in type 2 is usually controlled by non-insulin therapies. You may need insulin at some point later on for symptom control. Type 1 diabetic patients are otherwise normally healthy, but type 2 often have comorbidities like hypertension, dyslipidemia, sleep apnea, hepatic steatosis, polycystic ovaries, and it's often diagnosed after emergency admission for a myocardial infarct or a stroke. These are the different kinds of diabetes we have. So type 1 we said is due to a beta cell destruction, usually leading to absolute insulin deficiency. That's the key thing. You need insulin for survival if you are type 1 diabetic. Type 2 diabetes may range from predominantly insulin resistance with relative insulin deficiency through to a predominantly secretory defect with insulin resistance, right? Other specific types have to do with genetic defects in beta cell function. The poster child for that is MODY, maturity onset diabetes of the young. We also get genetic defects in insulin action, diseases of the exocrine pancreas, where we talk about pancreatitis chiefly, but other causes as well, endocrinopathies, drug or chemical induced, infection related, and other uncommon forms and genetic forms as well. Just want to mention hyperglycemia first detected in pregnancy. We split that two ways, either gestational diabetes or diabetes mellitus in pregnancy. Okay, guys. How do patients with diabetes present? So type 2 diabetic patients often have an insidious onset, but as in our clinical case, they can present with polyuria, polydipsia, polyphagia, all right? Fatigue and blurred vision, frequent infections like urinary tract infections, osteomyelitis, cellulitis, otitis media, vaginitis, balanitis. In-organ symptoms occur after long-term, poorly controlled disease. Retinopathy will manifest with blindness and cataracts, nephropathy with glomerulosclerosis, nephrotic syndrome, especially an increasing pattern in your lipids, right? Increased LDL, increased triglycerides, chronic kidney disease, hypertension. Atherosclerosis will manifest with cardiac disease, stroke, peripheral vascular disease, and then we have foot ulcers and gangrene, also hypertension. Autonomic neuropathy may show up with orthostatic hypotension, gastroparesis, urinary retention, neurogenic bladder, arrhythmias, and so forth. Peripheral neuropathy shows forth with decreased sensation in Charcot's joints. Okay, guys, let's talk a bit about pathophysiology. So we know that insulin is the key that unlocks the door for glucose to enter the cells. Now, glucose is the primary source of energy utilized by the brain, but it's also shunted into muscle for utilization, into the liver, where it is stored away as glycogen, so we can break it down in times of need by gluconeogenesis. This is also sensed by the pancreatic islet cells, and that serves as a stimulus for insulin release. And this diagram from Harrison's looks at the mechanisms of glucose-stimulated insulin secretion in abnormalities in diabetes. So glucose moves in via the GLUT receptor, and in the cytoplasm of the beta cell, glucose undergoes glycolysis, right? So glucose to glucose 6-phosphate shunted through to pyruvate. In the mitochondria, it releases ATP, and here we have ATP-sensitive potassium channel, so there's potassium efflux, right? And essentially this causes depolarization and causing a voltage-dependent calcium channel to open. Calcium moves into the cytosol, and then it undergoes secondary messenger systems like inositol triphosphate dioxyglycerol, which then stimulates the transcription of islet transcription factors, and it causes the granules to come forth and then for insulin to be produced and liberated. So that, in essence, is how glucose stimulates insulin production by the beta cells. Now, the problem inherently in type 2 diabetes is that the peripheral cells are insensitive to circulating insulin, right? And they then perceive, or the body perceives, that the body is starving, and so it wants to liberate glucose from non-carbohydrate precursors, right? So that leads to hyperglycemia. At the same time, the body is going to produce too much insulin, leading to hyperinsulinemia, and eventually these poor beta cells get exhausted. So it's a combination of peripheral insulin resistance with hyperinsulinemia and pancreatic cell burnout. Okay, what's the differential diagnosis for type 2 diabetes? So obviously type 1, insulin resistance syndrome, gestational diabetes, pancreatic diabetes in the way of chronic pancreatitis, pancreatic tumors and infections, systemic disease resulting in pancreatic insufficiency, and the poster children for that is hemochromatosis, cystic fibrosis, chronic pancreatitis, hormonal changes. Then we've got the endocrinopathies with acromegaly, fail, medication induced in the way of thiazides, steroids, beta blockers, oral contraceptive pills. We covered this in the table on a previous slide. Guys, how do we evaluate someone for diabetes, right? So very important in terms of our diagnostic criteria to know the metabolic cut points, right? So you can diagnose diabetes unequivocally if you have a fasting plasma glucose value of above 7 millimole per liter. If you do an oral glucose tolerance test and your post-OGTT 2-hour glucose value is above 11.1, if you got a glycated hemoglobin of above 6.5, and you got a random plasma glucose, often with symptoms of above 11.1 millimole per liter. That's unequivocal diabetes, right? Then we get so-called pre-diabetes, where your fasting plasma glucose is between 6 to 6.9 millimole per liter. Your post-OGTT 2-hour GM value of between 7.8 to 11. That's what we call impaired glucose tolerance. And a random between 5.6 and 11, which is somewhat inconclusive. But you can say with some degree of certainty that your patient does not have diabetes when your cut points are a fasting glucose of below 5.6, a 2-hour post-OGTT value of below 7.8, A1C below 6.5, and random plasma glucose below 5.6, right? But just remember, for all intents and purposes, 7 and 11.1. Measurement of islet cell antibodies or C-peptide levels may help us to distinguish type 1 from type 2 diabetes. You want to screen all patients older than 45 years every 3 years and earlier if they have risk factors or they have symptoms. Your glycated hemoglobin HbA1c level reflects glucose control over the last 3 months. You want to assess this every 3 months in diabetic patients until that target, and then annually thereafter. You want to assess diabetic patients regularly for the dreaded microvascular complications, all right? So to this end, you want to do yearly microalbuminuria, but the nomenclature has changed. Microalbuminuria is now called moderately increased albuminuria. We'll talk about that. You want to do that to assess renal function, and this basically equates to between 30 to 300 milligrams of albumin per 24 hours, which signifies early stage nephropathy. Then you want to do the renal function, the urea creatinine, which, as we know, is going to increase as the renal function declines, right? Annual dilated ophthalmological exams are recommended to screen for dreaded retinopathy. We'll see a few examples. Annual podiatric exam will help to reduce the incidence of diabetic foot infections. Always have a low threshold for stress testing, as ischemic cardiac disease may not present with typical angina in diabetic patients, right? They get silent infarcts. Okay, so who are you going to screen for type 2 diabetes, guys? Let's just talk about this. So anybody who's at risk. Who's at risk is adults at any age who are overweight, with a BMI of above 25 in general and even above 23 in Asians, plus one or more of the additional risk factors. So physical inactivity, hypertension, more than 140/90 systolic diastolic, or if the patient is already on treatment for hypertension, if the patient has a first-degree relative who already has diabetes, If the patient has dyslipidemia, polycystic ovaries, high-risk ethnicity, which being Asian, Indian, and colored. Asian, Indian, me, ha ha. Cardiovascular disease history, gestation diabetes, or a macrosomic baby before or currently, previous impaired fasting glucose or impaired glucose tolerance, and other conditions also known to be associated with insulin resistance, right, like acanthosis nigricans, severe obesity. If there's no risk factors, anybody above the age of 45 should be screened. Frequency, you want to screen them at least at 3 yearly intervals if normal, and more frequently based on initial results and risk status. How do we screen them? Either with a fasting plasma glucose, a formal OGTT, or glycated hemoglobin, but the OGTT is the preferred test in high-risk individuals. Okay, guys, let's touch on treatment and management of type 2 diabetes. Now, many patients with type 2 diabetes will eventually develop a requirement for insulin once oral medications are no longer effective at controlling blood glucose. But unlike type 1 diabetes, where insulin is necessary for survival, we can obtain relatively adequate glycemic control on oral agents alone in type 2 diabetes. Even though type 2 patients may ultimately require insulin, they will still benefit from adjunctive oral meds to improve the peripheral insulin sensitivity. Now, a reasonable insulin starting regimen in type 2 patients includes a once daily injection of, like for instance, Profane, which is a long-acting agent, with oral medications with sensitization, right? Now, this is how we select our A1C targets in type 2 diabetes as per the SEMDSA guidelines. So if your risk of hypoglycemia or drug interactions are low, you want to be, a bit more strict with the glycemic control. But if your risk of hypoglycemia is high, then you want to be less strict, with aiming for A1C of between 7 to 8%. If you have diabetes for a long time, then we want to be less strict with glycemic control, but if it's newly diagnosed, you want to get good control. If life expectancy is long, you want to target an A1C below 6.5%, but if it's short, be less strict about that. If the patient has major comorbidities, right, then you want to be less strict with your A1C, but if it's absent, you want to be more strict. If the patient has established macrovascular disease, right, then you want to be less strict, but if these are absent, then you want to be more strict. If your patient has a good attitude, is highly motivated, adherent, has good self-care capacity, then you can aim for a lower A1C. But if the patient is not motivated, not adherent, has poor self-care, a higher A1C. Right, especially those patients who had cerebrovascular accidents before. If resources and support are readily available, you can aim for a lower A1C, but if the patient has poor support system, poor resources, aim for a higher A1C target. Okay, in Harrison's, it tells us the different arms of managing type 2 diabetes. So on the one hand, you have individualized glycemic control. On the second hand, or arm, you have treatment-associated conditions, and then you have screening, right, for complications. So in terms of individualized glycemic control, we talk about diet and lifestyle management, exercise, and medication. In terms of associated conditions, you target and treat dyslipidemia, hypertension, obesity. We'll be covering those. And then you want to screen for and manage complications of diabetes in the way of retinopathy, nephropathy, neuropathy, cardiovascular disease, and other sequelae, right? Now, these are our treatment goals. We've already covered our A1C targets, but let's just look at our treatment goals as per Harrison's. So it's divided into those younger, non-pregnant adults and those who are older and high risk, right? So amongst the younger folks, you want to aim for an A1C target of below 7%, which is 53 millimole per mole. In the older folks, you aim for A1C of below 8%, which is 64 millimole per mole. In terms of targeting your preprandial capillary blood glucose should be in the range of 4.4 to 7.2 in the younger folks and somewhat less strict between 5 and 7.8 in the older folks. Your postprandial blood glucose should be ideally below 10 in the younger folks and below 11.1 in the older folks. The time within the range of GM of 3.9 to 10, you should be in this range at least more than 70% of the time. In if you're younger and if you're older, in this range more than 50% of the time, right? Time in a hypoglycemic range, which is below 3.9, you should be here less than 4% of the time if you're younger, or less than 1% of the time when you're older. So our A1C target in the older folks is less strict. Right, in terms of glucose variability, it's mentioned there. Guys, this is a very busy slide, but I think it's important for us because this mentions the pros and cons of our different therapies for type 2 diabetes in terms of what options we have available. So we have them in the oral form, we have parenteral and oral, and we have parenteral. So the mainstay, the Rolls Royce, is the biguanide. Metformin is a poster child for that. It acts by decreasing hepatic glucose production, increasing insulin sensitivity, and influences gut function, right? It reduces your A1C by 1 to 2%. The biggest advantages of this is that metformin is weight neutral, does not cause hypoglycemia, it's inexpensive, and also has proven cardiovascular benefits. The disadvantages of metformin is the GI effects, diarrhea, nausea, lactic acidosis. It causes B12 deficiency. It's contraindicated at a GFR of below 30 mL per min and in heart failure because of the risk of lactic acidosis. All right, those are the main ones. Then the next agent is the sulfonylureas, which are secretagogues, essentially. They increase insulin secretion. The poster child for that is limepiride, but we also get gliclazide and so forth. They reduce your A1C also by 1 to 2%. The advantages here is a short onset of action. It lowers postprandial glucose. It's relatively inexpensive. But the drawbacks is that it causes hypoglycemia and weight gain. It's contraindicated in renal and liver insufficiency, right? Then we have the thiazolidine diones, like pioglitazone and rosiglitazone. They decrease peripheral insulin resistance and increase glucose utilization. They reduced your A1C more modestly, between 0.5 and 1.4%. The advantages is that they lower insulin requirements, but the disadvantage is they cause weight gain and they cause peripheral edema and heart failure. There's also a link with fractures and macular edema. They are contraindicated in congestive heart failure, renal and liver insufficiency, right? Then we talk about some of the relatively newer agents, the dipeptidase 4 inhibitors, the likes of your gliptins, your saxagliptin, your sitagliptin, right? And they act by prolonging your endogenous GLP-1 action, right? They increase insulin and decrease glucagon. In general, the advantages is they're well tolerated. They don't have the propensity for causing hypoglycemia, but the disadvantages is that they have the likelihood of causing angioedema, urticaria, and immune-mediated derm effects, right? You want to apply dose reduction in cases of renal insufficiency, right? Then you get your SGLT2s, your sodium glucose co-transporter 2 inhibitors, the likes of canagliflozin, dapagliflozin, empagliflozin, or the gliflozins, right? They act by diminishing your renal glucose excretion, and they reduce your A1C by about 0.5 to 1%. The advantages is that they do not cause hypoglycemia, they decrease weight and blood pressure, they are known to have renal benefits, they reduce cardiovascular events, so they have cardiovascular benefits as well. The disadvantage is that they cause urinary and genital infections, polyuria, dehydration, and exacerbate the tendency towards hyperkalemia and DKA, contraindicated in moderate renal insufficiency and insulin-dependent diabetes. Guys, we also have the alpha-glucosidase inhibitors. You got the other insulin secretagogues, which are non-sulfonylureas, just to mention those. Then, of course, the GLP-1 receptor agonists, these are available either parenterally or orally. Here we talk about liraglutide and company. They act by increasing insulin secretion, decreasing glucagon, and slow gastric emptying and satiety. Their main point is that they promote weight loss. They don't cause hypoglycemia unless they are combined with insulin or another secretagogue, and they have proven cardiovascular benefits. But the drawbacks is injection. These in the form of injections cause nausea, pancreatitis. Contraindications are renal disease, agents that slow GI motility, medullary CA of the thyroid, and pancreatic disease. Then the parenteral options, guys, we have amylin agonists like pramlintide, we have insulin, and then we talk about medication, nutrition, and physical activity. But insulin, as we know, it acts by increasing glucose utilization. So insulin is the key that unlocks the door for glucose to enter the cells. It decreases hepatic gluconeogenesis and other anabolic actions, right? It has no safety profile, but remember, this is an injection. It causes weight gain and hypoglycemia, alrighty? Now, these are some of the factors to consider when choosing a therapy for type 2 diabetes, right? Let's have a closer look at this. So in terms of reduction in the A1C, right, all of them, essentially, all of these options, the gliclazide, the pioglitazone, the DPP-4s, the GLP-1s, SGLT2s, basal insulin, they reduce the A1C by around about the same figures, right? Propensity to hypoglycemia with monotherapy, your sulfonylureas definitely, your insulin definitely. In addition to a sulfonylurea, pioglitazone more so than the others, right? In terms of adverse events, we said that your thiazolidine diones have the propensity for causing edema and congestive heart failure. Saxagliptin can cause heart failure. GLP-1s cause GI upset. SGLT2s are associated with genitourinary infection and dehydration. Insulin, as you know, can cause local skin reactions, fat hypertrophy, right, and atrophy. Rare side effects that pioglitazone has been associated tenuously with fractures and bladder cancer, DPP4 inhibitors with pancreatitis and pancreatic cancer, as well as GLP-1s. SGLT2s can cause fracture, amputation, DKA. Treatment complexity of thiazolidinediones is high, as well as the SGLT2s and insulin is high. GLP-1s intermediate, DPP4 and glycolysis and your sulfonylureas not so. Which ones have cardiovascular benefit? Right, so your pioglitazone, yes. Your GLP-1s, yes. Your SGLT2s, yes. Cost is mentioned here, all right, as we can see. And those that you want to initiate first or second line include your sulfonylureas. You can use your thiazolidinediones, your TPP4s, right? Insulin is generally third line together with the GLP-1s. SGLT2s, second line. Okay, what are independent risk factors for severe hypoglycemia, guys? So if the patient indeed is using insulin or any of the secretagogues, chiefly your sulfonylureas, intensive glucose control, use of 2 or more concomitant glucose-lowering drugs, the older folks because of hypoglycemic unawareness, diabetes duration, hypoglycemic unawareness, impaired cognitive function, lower body mass index, renal impairment, and macrovascular complications. Circumstances in which the consequences of hypoglycemia may be catastrophic. Important to ask about the occupation of your patient. Operators of heavy machinery, scaffold workers, drivers of public transport or heavy-duty vehicles, airline pilots, emergency rescue workers, those who live alone and have impaired cognition or mobility, especially those who had a CVA before, hypoglycemic unawareness, people at high fall and fracture risk. Guys, hypoglycemia and diabetes, right? So we define this in terms of 3 different levels. Level 1 is those who have a GM of below 3.9, which is sufficiently low for treatment with fast-acting carbohydrate and dose adjustment of glucose-lowering therapy. Level 2 is where we have clinically significant hypoglycemia in which the GM is less than 3, which is sufficiently low to indicate serious clinically important hypoglycemia. Level 3 indicates severe hypoglycemia, right, where there's hypoglycemia in association with severe cognitive impairment, usually with seizures, and they require external assistance for recovery. Okay, guys, let's just outline diabetic emergencies. Just want to draw the common ways to stratify DKA from HHS. On history, we know that DKA often complicates type 1 diabetes or is a novel presentation of type 2, but HHS usually in type 2 or newly diagnosed. Precipitants for DKA is infection, non-compliance in insulin, but precipitants for HHS, infection, MI, CVA, diuresis, right, because of the dehydration that is involved. Usually DKA happens in younger patients, HHS in older patients, but not exclusively. The onset in DKA is hours to days, but that in HHS is days to weeks. Symptoms are common between both, right? Polyuria, polydipsia, anorexia, nausea, vomiting, somnolence in those who are hyperosmolar. Signs is customers' respiration in DKA, which reflects that the patient is trying to blow out that increased acid, okay? So deep sighing, breathing, dehydration, confusion, nausea, vomiting. But in HHS, it's mainly mental status changes, severe dehydration, sometimes seizures, okay? Urine ketones are strongly positive in DKA, not so with HHS. Serum ketones as well. Blood glucose is raised in DKA, but more so in HHS. The blood pH is decreased because the patient's acidotic in DKA, but the pH is probably normal or slightly decreased in HHS. Serum bicarb is low in DKA, not so with HHS. Alrighty. These are nutritional recommendations for adults who have diabetes and prediabetes. In general, we recommend foods which are low in GI, so vegetables, fruit, whole grains. The fat, in terms of fat content, Mediterranean style diet, minimal or no trans fat consumption. In terms of your carbs, you want to monitor your carb intake in relation to calories and set limits for meals to reduce the incidence of postprandial glycemia. Avoid fructose and sucrose containing beverages, right? And then you also want to estimate grams of carbohydrate in the diet for flexible insulin dosing. That's more with regard to type 1 diabetics and those who are insulin dependent type 2. Right, and then other things is that you want to reduce your calorie and non-nutritive sweeteners. I'm sorry, these may be useful, right? And routine supplementation of vitamins, antioxidants, trace elements, sodium intake as advised for the general population. Guys, this is just looking at the recommendations as per SEMDSA for aerobic exercise, right? So definition of aerobic exercise is activity that consists of rhythmic, repetitive, and continuous movement of the same large muscle groups for more than 10 minutes at a time. We stratify them in terms of intensity, frequency, and examples. So the recommendation is if you're doing moderate exercise like cycling, brisk walking, right, where you reach about 50 to 70% of your maximum heart rate, the recommendation is this, a minimum of 150 minutes per week. Or if you're doing vigorous exercise where you're going over 70% of the maximum heart rate, like jogging, aerobics, hockey, fast dancing, You do this at least 75 minutes per week, or you can do a combination. What about strength training, guys? Resistance training entails activities of brief duration involving the use of weights, weight machines, or resistance bands to increase muscle strength and endurance. The recommendation is 2 to 3 times per week, right? Okay, guys, let's just quickly look at diabetes-related complications. Right, as per Harrison's, we talk about macrovascular, and others. Microvascular is eye disease in the way of retinopathy. We split that into non-proliferative and proliferative macular edema. Neuropathy, we talk about sensory and motor, which can be mono or polyneuropathy, autonomic, and nephropathy, in which we quantify your albuminuria and your declining renal function. Macrovascular, there's coronary heart disease, peripheral arterial disease, cerebrovascular disease, a whole host of others as well, like gastrointestinal, the way of gastroparesis and diarrhea, genitourinary, the way of uropathy and sexual dysfunction, retrograde ejaculation, impotence, dermatological issues like diabetic dermopathy, acanthosis, cataracts, glaucoma, chiroarthropathy, periodontal disease, and hearing loss. All right, and a whole lot of other comorbidities as well. I just want to draw attention, guys, to our cardiovascular risk factors and targets for patients with type 2 diabetes. All right, so ideally you want smoking cessation, and you want to counsel regarding dyslipidemia. These are our targets: a total cholesterol of below 4.5 millimole per liter, LDL of below 1.8, trigs of below 1.7, and in HDL we aim for a value of above 1 in men and above 1.2 in women, because HDL is a good cholesterol. In terms of obesity, you want to aim for the waist circumference below 94 centimeters in men, but if you have South Asian descent, below 90 centimeters, right? And in women, below 80 centimeters waist circumference. BMI, ideally below 25. Hypertension, aim for a systolic below 140 and diastolic below 90. But if you've got concomitant CKD, that becomes less than 130/80. Okay, this is the harmonized criteria for the clinical diagnosis of metabolic syndrome, right, which keeps company with type 2 diabetes. So an elevated waist circumference, which is population and country specific. From sub-Saharan Africa, these are the cut points, right, in males and females, European, Asian, and Chinese respectively. Elevated triglycerides above 1.7, reduced HDL below 1 in men and below 1.3 in women, elevated blood pressure above 130/85, and elevated fasting glucose. These constitute, right, the harmonized criteria for diagnosing metabolic syndrome. This is how the WHO will classify your BMI. So if you're below 18.5, you're underweight. Normal is between 18.5 to 24.9. Overweight between 25 to 29, and obesity cluttered 3 ways. Class 1 is between 30 and 34.9. Class 2 between 35 and 39.9. Class 3 is over 40. Guys, taking a closer look at diabetic retinopathy, just in a nutshell, right? So the first stage is basically mild non-proliferative diabetic retinopathy, where we have localized swelling of small blood vessels in the retina, so we have microaneurysms. Then we get moderate non-proliferative flavor, where we have the microaneurysms plus small bleeds, which is what we term dot and blot hemorrhages, leaks, which are hard exudates. We can see some here, all right, or closure, which is cotton spots, right, and small blood vessel. Then we have severe non-proliferative, is where we have the moderate plus further damage to blood vessels, and then we have intraretinal hemorrhages, venous bleeding, intraretinal microvascular abnormalities. Then, of course, the last stage is proliferative diabetic retinopathy, with this new vessel formation or vitreous or pre-retinal hemorrhages, and we have the formation of new vessels, right, because of VEGF, vascular endothelial growth factor, which causes angiogenesis. And these new vessels are very fragile, they have a tendency to bleed, and as they heal, they pull off the retina, so you end up with retinal detachment and blindness. Okay, this is illustrating a glomerulus, right, and the changes induced by diabetes. And this is a beautiful example of how 10 years of normal glycemia results in actually reversal of the glomerular sclerosis and the arteriolar hyalinosis, which is, as we compare the figure on the left, which is pre-pancreatic transplantation, versus the image on the right after 10 years of normal glycemia. Okay, the different stages of diabetic kidney disease, guys. Look at the dipstick, right, which is not that sensitive really. A more sensitive way of quantifying renal impairment is by the albumin to creatinine ratio, as we know, alrighty. And if it's negative, it'll be less than 30 milligrams per day, right? And that then progresses to microalbuminuria, which is what we define as moderately increased albuminuria, which is between 30 to 300 milligrams per day, to overt albuminuria, which is at least 1,000 milligrams per day. If that progresses, it can go into nephrotic range proteinuria, which is above 3,500 milligrams in 24 hours. So that's what we just discussed here, right? The different stages of CKD based on albuminuria. Stage 1, 2, 3 with the albumin excretion rates being less than 30, between 30 and 300 and over 300 milligrams per day respectively. This is the KDIGO classification, guys, looking at our different stages of CKD. I'm sure we're familiar with these, right? Stage 1 through stage 5. So stage 1 is when your GFR is above 90. Stage 2, when you get GFR between 60 and 89. Stage 3 is 3A and 3B. 3A is when your GFR is between 45 and 59. 3B when it's between 30 and 44. Then stage 4 is when it drops between 15 and 29. Where you want to actually plan for dialysis of some sort, or renal replacement therapy, and of course, if stage 5 when your GFR drops below 15. Alrighty. Now, let's look at how we're going to modify some of our anti-diabetic drugs in type 2 diabetes. Okay, let's just remember a pointer in there. So your second generation drugs, right, the sulfonylureas like glibenclamide, glimepiride. In terms, if you got stage 3 and 4 CKD, you really want to avoid these or initiate at a lower dose. Okay, the same applies with your glucosidase inhibitors like acarbose. Not recommended if your serum creatinine is above 180. Right, metformin contraindicated when the GFR drops below 30. Thiazolidine diones require no dose adjustment. Meglitinides as well, right? No dose adjustment. But if the patient's on dialysis, ideally you want to avoid most of these. Alrighty. So we covered retinopathy in our previous slide. When do you want to refer a patient to ophthalmology? Right, so urgent referral, obviously, if you got sudden visual loss, retinal tear detachment, proliferative diabetic retinopathy. Right, referral within 3 months if you got unexplained gradual worsening of vision, non-essential, right, visual acuity below 6 out of 12, severe non-proliferative retinopathy, and symptomatic visual complaints. Referral within 6 months for all others, including glaucoma and cataract. Okay, so in terms of the diabetic foot ulcer prevention plan, we speak about general measures, education, foot exam, risk categorization, and management, right? So in terms of general measures, you want to optimize your glycemic control, blood pressure, and lipids, smoking cessation, weight loss. And to educate the patient about foot care advice and footwear inspection and advice, don't walk around barefoot, wear comfortable insoles, right? Foot examination in terms of the skin, the bones for obvious deformities, the nerves for neuropathy, and the vessels for peripheral arterial disease. Then you categorize the risk in terms of low, moderate, and high risk and management, in terms of non-ulcerative pathology, and plan referral and follow-up. Guys, let's talk about prognosis and complications. So diabetes, as you know, is the leading cause of blindness in persons aged between 20 and 74 and of end-stage renal disease and non-traumatic lower extremity amputation. Type 2 diabetes, which is associated with metabolic syndrome, is characterized by, like we said, insulin resistance, central obesity, hypertension, low HDL, and elevated trigs. These keep company. And diabetes is considered an immunocompromised state due to white cell dysfunction, so all infections should be evaluated and treated aggressively while keeping in mind the usual culprits in infection, for instance, Pseudomonas. Right? Always inquire about episodes of hypoglycemia and tailor meds to treat that accordingly, guys. So coming back to our clinical case, just to jog our memory a bit, we had a 37-year-old obese lady who comes in. Over the past year, she had 2 yeast infections, which she addressed with over-the-counter remedies. She's got polydipsia, she's got nocturia. Which of the following is the most appropriate first test in evaluating for diabetes? Random plasma glucose level. So we said that the cut points here, which we're familiar with already. Because she has symptoms, she is not being screened for diabetes. For screening, the fasting plasma glucose or A1C is recommended, right? But ideally, your fasting plasma glucose value above 7 or your A1C above 6.5 will clinch the diagnosis for us. Alrighty. Guys, let's talk about the Bible for a bit, right? Let's talk about living in the end days, right? What does the Bible say about this? In Matthew 24, verse 68, Jesus told us, "You will hear of wars and rumors of wars, but see that you are not alarmed. Such things must happen, but the end is yet to come. Nation will rise against nation, kingdom against kingdom. There will be famines and earthquakes in many places. All these are the beginning of the birth pains." My friends, whenever we even switch on the news on TV or on radio or social media, and we see so much of anarchy in the world, so much of crime, so much of unemployment, so much of pestilence and disease, people losing their lives. We see these characteristics in the end days, but do not be discouraged. These things must happen. I pray that we will have a view of eternity in mind and live holy lives by the power of the Holy Spirit within us, so that we will be with Jesus. Alrighty? Do not be discouraged. Do not be dismayed. Okay, 2 Timothy 1:7 says, "For God has not given us a spirit of fear, but one of power, love, and sound mind." Power, love, and sound mind. These are my references. Thank you so much for joining me. We're going to be covering congestive cardiac failure soon. You can check me out on my Facebook page. It's called Algorithms in Internal Medicine, Algorithms and Mnemonics in Internal Medicine. I'm also on TikTok and on Instagram. Looking forward to your friendship on those platforms. God bless you. Have a lovely day.